I asked him to give me a brief CV, and this is about as brief as he can get. In the past, he's usually given me a 3 or 4 page CV. You all know Dr. Bouquot. Let me tell you a little bit about his background. He received his DDS and his MS degrees from the University of Minnesota, with postdoctoral fellowships to the Mayo Clinic and the Royal Dental College in Copenhagen, Denmark, as the recipient of a Career Development Award from the American Cancer Society. For 20 years, he was on the faculty of West Virginia University, and 17 years of that as chairman of the Department of Oral and Maxillofacial Pathology. During that time, he received more outstanding teacher awards than any other medical center facility or faculty, including West Virginia University's highest teaching award. He also received the university's highest award for service to the state of West Virginia and has received several national and international awards for his achievements. He's now the Director of Research for the Maxillofacial Center for Diagnostics and Research in Morgantown, West Virginia, and the State Director for West Virginia the Dental Organization. That's not true anymore, is it?
As of this week, no.
Good. They don't appreciate you anyway. He's also the Director of Head and Neck Diagnostics of America, one of the nation's largest oral pathology biopsy services, and I think most of you who do biopsies probably send your reports or your specimens to Dr. Bouquot. He has been a senior visiting scientist at the Mayo Clinic, a special advisor to the National Institutes of Health, and a teaching consultant to Pittsburgh's Children's Hospital. As a past member of the Research Committee for the American Cancer Society, he was one of 32 professionals responsible for annually reviewing and approving almost $100 million in cancer research grants. How come I never got any?
You didn't deserve them.
Dr. Bouquot has more than 120 published papers, abstracts, and book chapters. His work has been translated into several languages and cited hundreds of times in the literature. He is a co-author of the best-selling textbook of oral pathology and is a reviewer for several journals, including the New England Journal of Medicine and the Journal of the American Dental Association. He has presented more than 800 research talks and continuing medical education seminars throughout the world. He is Vice President of the American Board of Oral and Maxillofacial Pathology and has been on the Executive Council of the American Academy of Oral and Maxillofacial Pathology. He has several times been president of his state's American Cancer Society, and he is a member of the National Assembly of the American Cancer Society. I have chronic fatigue just saying all that. I want to introduce
Can you pull it too?
Terry Bouquot.
Thank you, Chris. I'd like to thank you all for welcoming back. For those of you who heard my much longer discussion on this disease about 4 years ago, I think now, that was a bit of a disaster because the slides I put together for that talk, instead of the letters coming out white, they came out black, so you had to kind of pretend that you knew what I was talking about. This time I hope it's a little bit better. It's certainly shorter, and that'll be better. But for those who haven't heard me talk, I should explain a little bit. I've been the oral path consultant for our state licensing board for a long time. I've taught so many people, so many dentists in my state that the majority of dentists, including those on the board, are my students now. So it's kind of nice having a different relationship with boards than most people have. But the board asked me to look at cases of this disease, NICO, in order to see whether they should take the license away from an oral surgeon who had been doing this for 30 years. And I knew nothing about it. He was the only oral surgeon, almost the only oral surgeon in my state who did not send his biopsies to my lab. And I had been told deliberately to stay away from this quack, and so I did. And I unfortunately was asked to look at 10 cases microscopically. The fellow was a meticulous record keeper. All of his work was done in the hospital in those days. So there were BACT lab values. There were all kinds of there was all kinds of workup by physicians. So his documentation was excellent, and I diagnosed microscopically all 10 cases as chronic osteomyelitis. That was sent without my knowing it. Those same cases were sent to the chairman of pathology at the West Virginia University School of Medicine, and he called them all chronic osteomyelitis. And we sent them, or they were sent to the chairman of the oral path department at Harvard, and he called them all chronic osteomyelitis. Well, if you look in a bone pathology textbook, there isn't chronic osteomyelitis. There's chronic sclerosing osteomyelitis that those of us who are dentists are familiar with. And there's a granulomatous type of thing that we get with tuberculosis and some of those deep fungal infections as well. But we're kind of inventing the wheel here to come up with something called chronic fibrosing osteomyelitis, which is what I called the first 2,000 cases of this disease. I'm a little bit, hopefully a little smarter now than I was back then, but you'll have to decide for yourself about that. Oop, these buttons are reversed. I want to warn you, I do come from West Virginia. We have our, just as the Georgia people have their little foibles and problems, we have our stereotypical problems. As soon as I went to West Virginia, being trained in Minnesota, that is sort of the place where Dr. Gorlin, Mr. Syndrome, was there. He was my trainee, or my mentor and boss. And he sent me a list of people with inbred families, and it was a computer list that must have been 1.5 inches thick. We do have a lot of inbreeding in my state, and there is a lot of genetic damage, I guess you might call it. But for the most part, we never see the real hillbillies. West Virginia is just like any other state, as far as I can tell, except there's not a lot of money there. We have a little different view of the state. Maybe we can turn the light off, or do you need the light for? Oh, okay. We have a little different view of the state for those of us who live in the state. This is just 5 minutes from my home. And that's about 15 minutes from my home. And this is in my hometown. We have one of the larger balloon festivals in the East Coast every year. And it's gorgeous with the fall colors. I have loved this state mostly because of this. This is Morgantown, West Virginia. It's a town of 28,000 people. And how many dental schools are found in towns with so few people? So it's been a pure joy to work, and until we got a new dean, I had no intention whatsoever of leaving West Virginia University. Something fairly unique about a town like this, the only thing that ties the whole state together, because we have a north-south division in West Virginia. The people in the north are Yankees, and the people in the south have a different accent, we say. But nevertheless, football and basketball are the two things that tie us all together, and National Public Radio is the other. Every station in the towns in West Virginia are tied together, or is tied with one another. This is our stadium. This stadium holds 72,000 people. The town holds 28,000 people. Even if you put all the university students, that's only 23,000 more people. And we fill this routinely. But if you look carefully, you'll see this is the medical center. The new hospital here is under construction right in front of the old hospital, and there's a building that is quite long back here for the classrooms. But as with so many real big city types, we put the hospital and the football stadium right next to each other. And so the saying goes, you never want to have a heart attack unless you're watching a football game, because you'll never get there because of all the traffic. And of course, this is really what West Virginia has been known and becoming even more known for, whitewater rafting. It's got 3 of the 6 highest ranked whitewater rivers in the country. We do have the highest single arch bridge in the country. Once a year, we have a bridge day. We close, this is a freeway, we close 2 of the lanes and jump off the bridge. People literally come from all over the world. We have 100,000 people on this bridge on Bridge Day, and they bring their own parachutes, fortunately. And about every 3 or 4 years, somebody doesn't open it up in time, or chute doesn't open it up. But from here to the water's edge is almost 1,000 feet. And there we go, on Bridge Day. Well, that doesn't have much to do with what I'm going to talk about. But there is another sort of West Virginia connection. This is a textbook that I talked 3 other co-authors into publishing. It's published by Saunders, the biggest medical text publisher in the world. It has become the standard text. It's required in almost all dental schools. And it really has been a neat experience, but you can't see the Neville is the first name on top, Neville. Brad Neville was one of my students in the WVU Dental School. Doug Dam is a hillbilly from Kentucky and Arkansas originally. Carl Allen was born in West Virginia and spent his first few years there. And of course, I'm a West Virginian, so amongst ourselves we call this the hillbilly textbook. And it has 2 pages on NICO. NICO is, by the way, in now 6 all standard textbooks in dentistry and medicine. It will be in 2 more, possibly 3 more by the end of this year. So it's come a long way in a fairly short period of time. But this is not my main interest, or it wasn't until circumstances forced me to become more involved. My main interest has been oral precancers and my major research. And of course, with my connections with the American Cancer Society, I'm the guy who goes around and talks to the junior high school kids and the high school kids. And so NICO is quite a break from the kinds of things that I normally deal with. When I first got involved in this, it was called in my state Robert's bone cavities because he wrote a paper, the oral surgeon in West Virginia whose material I looked at. And it was also called Ratner in the rest of the country, Ratner cysts or cavitations. And I decided that before I gave my first talk, which was in Ireland of all places, on this disease, I needed a name that wasn't so controversial. And I wanted to emphasize the 2 major features of this. The pain that's produced by this disease is neuralgia-like. The pain that's induced or produced is most often mistaken, I like to say, for a true neuralgic pain. And so I wanted that in the name, and cavitational, of course, is a very, 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 very unique feature of bone and only is seen in certain conditions. And just before I went over to Ireland, this was in '90, I guess, to give this talk, I read my first paper on osteonecrosis. I had already gone through the entire literature on osteomyelitis, and it kind of matched what I was looking at, and I felt okay with my diagnosis. But once I got into the medical literature on osteonecrosis of the hip, everything they said fit right in with this disease that I'm covering today. And so, and Chris Husser is going to finish covering. And so NICO has become a fairly standard term now. Unfortunately, that's got its own set of controversies around it. But I can say quite truthfully that probably 25 or 30 dental schools have now sent me either tissue, x-rays, Jer, can you rule out NICO? I've got 3 of those from universities on my desk right now, my secretary tells me. Or they've sent patients. And so even though there is some controversy is normally not a real problem. Oral pathologists sort of like controversy. And I want to emphasize before we begin that we've got a name, and this name seems to have stuck and probably will stick. However, that doesn't mean we understand exactly what's going on. And boy, did I prove this law. I had no idea what I was getting into. I thought all I had to do was describe it because no pathologist had ever looked at this tissue and given a proper description. And then I thought, well, then I'll have to describe the x-ray changes, and finally I'll have to describe the follow-up studies. And I've done all that, but it's been really an uphill struggle. And I still have no idea how much further down the bottom of this pool is. I've also found this to be quite true. I had no idea what it was like working in the chronic pain business. I don't, of course, treat very many people. I don't do any of these surgeries myself. I've looked at probably over 100 cases now, but I've been watching other surgeons do the work. But boy, there are a lot of people with opinions who know much, much more than I do about this. Yes. I have had to defend my contributors in about 4 or 5 now, either courts of law or dental boards, and we've won all of them so far, but it sure takes a long time to get through that process. Well, there's a bit of history about this. I didn't even know until I started reading about reading as much as I could about a lot of different aspects of this disease that G.V. Black wrote an oral pathology textbook. But he did in the year that he died. And right after his osteomyelitis section, which was quite extensive because that was every dentist treated osteomyelitis big time in those days, he wrote about this other disease. He said it's kind of funny. It's a little bit like osteomyelitis, but there's no pus or maybe not even be any pain. He made up a name, chronic osteitis, for it. And he said it kind of eats away the bone, and the bone dies cell by cell. And the only way to treat it, the best way to treat it, is to go and scrape it out. And that's essentially where we are today with a few exceptions. Then nothing really much happened with this disease until the mid-60s or mid-70s. There were people working on patients with this problem, however. But as far as publishing things, Adler wrote his text where he discussed interference fields. Several NICO cases are in that text. Ratner had a quick and dirty abstract in '76. And then Ratner and Roberts really wrote the sort of the definitive beginning of this disease back in 1979 with a whole series of cases. And of course, everybody was talking about chronic osteomyelitis at that time. We've got some Chinese papers, Russian papers, German papers. There are altogether about 22, I think, research papers with reference to this disease. What is it? Well, I told you it's like osteomyelitis, but it's not like osteomyelitis. There is a disease out there. Aseptic osteomyelitis is the old term. That might be the term that some of you still remember it by. Aseptic necrosis is another term. If you want to run a Medline search, avascular necrosis is the term used. More frequently nowadays, the articles themselves use the title ischemic osteonecrosis, and I think that's the term that's going to stick. There are very few experts in this disease, very, very few. In the entire world, I think there aren't more than 5 or 6, and there are 4 of them in North America. I have visited personally with all of them. I've exchanged cases with them, and they agree that this is the disease. The disease I'm looking at is the same as what they're looking at in the hip. We all have known about a form of this disease, osteoradionecrosis. When I have to try to convince a surgeon into dealing with a patient, I just tell them to pretend this patient's been irradiated. She had a tongue cancer and was irradiated for tongue cancer, and now do what you would do for the bone. And with a lot of surgeons, and they seem to click, okay, I can handle it now. I know what I'm dealing with. And it's legitimate because radiation to the bone is one of the things that produces this. One of the hottest items in bone orthopedic surgery right now, if you look at the literature, is right here. Corticosteroid-induced osteonecrosis is a formal name. As much as 1 week of dose pack, Medrol dose pack, has produced a hip 4, 5, 6 months later that was destroyed to the point of total collapse. One of the oldest forms of this disease, but not known outside of the field of Navy divers and people who work in building deep tunnels and deep sea divers. This used to be called Caisson's osteomyelitis. Now the preferred term is dysbaric osteonecrosis. And the bone dies from going in and out of these different pressures rather than what we used to think they died from, and that was bubbles in the bone. And going back to a little after the turn of the century, there were 3 people from 3 countries that developed Perthes disease, is mostly what it's called here, and that's in the hip of young boys, and it's the same exact disease. I have put together a handout that was fairly recently updated, and you'll see on the first page of the handout a skeleton, and all along the outside of that skeleton will be a list of diseases that are in the literature as separate diseases, but they're all turning out to be the same phenomenon. So osteonecrosis is a very unique name. It means dead bone, of course, but you can't use it just for any dead bone. And this fellow, Arlet from France, probably set the whole field of osteonecrosis study ahead by half a century, almost instantly, with 10 years worth of work. He and a colleague, Ficat, F-I-C-A-T, were, if I'm pronouncing that correctly, were so instrumental that the first two Osteonecrosis International Symposia were dedicated to these individuals. And they were much more unique than anybody else because they said anybody can diagnose this when it's all dead. We want to look at the early cases, the mild forms of the cases, maybe the moderate forms of the cases, because that will tell us what the disease is all about. Well, as it turns out, NICO, the jaw form of this osteonecrosis, is almost all, at least at a microscopic level, is almost all the mild or the moderately severe form of the disease. And so we have a unique opportunity to understand a disease, and it's already gone forth that way. We have helped to explain some things going on in other parts of the human skeleton because of what we found in the jaws. Well, this is that picture. In the head neck area, in the jaws in particular, there is another form of avascular necrosis. It's called that to this day. It causes collapse of the condyle. It's quite a bit different from NICO, which is an alveolar bone process. And NICO is predominantly a pain-producing disease as we know it today, but who knows what proportion will have pain as we find out more about it. This is not a pus-producing disease. I hardly ever see, even at a microscopic level, pus. It may or may not have pain. It usually does, at least the cases we're aware of. It doesn't produce any change of the overlying alveolar mucosa or gingiva. Things don't get red. Things don't puff up. It doesn't. These are traditional anyway. There's no fever. There's no elevated sed rate. There's no elevated white count. The immunoglobulins are not elevated. It doesn't have all of the trademarks that are required essentially for an infection. It has a very subtle radiolucency that I'll get into, and when we culture these, we can usually find bacteria, but they're at such low levels, low quantities, and it's such a mix that we have to assume that no one bacteria is producing this. We haven't looked at protozoas, we haven't looked at viruses. I can rule out fungi because I would normally see that microscopically. But maybe there's another microorganism involved here. But it seems that the bacteria are, in most cases, just sort of secondarily riding along with this disease. Osteonecrosis is a disease of poor blood flow. Something produces poor blood flow, and in the handout I have one page of about 30 different things that can produce poor blood flow. Until the last decade or so, the two most common causes of osteonecrosis in the hip were trauma and infection. And which bones in the human body do you think have the most trauma and the most infection? I mean, every tooth extraction is a prime candidate for this disease. And the fact that we haven't diagnosed it in the past really has to do with this problem. When somebody is attuned to this, it's been my experience that they can find these entities, and I think many people in this room are good examples of that. So it's not really an osteomyelitis, but there are frequently osteomyelitis types of overtones. And to make the matters even worse, osteomyelitis itself can cause ischemia. All the inflammatory mediators, many of them cause clotting locally, and the blood supply is shut down locally in this area. So we have to keep in mind this is a disease that probably we have to use or think of the word threshold. You have several things going on. Somebody has an underlying problem, whether they had corticosteroids and all of their fat cells puffed up to the point where they put pressure on the veins and inside of all the bones, and the fluid, the blood could not leave the bones as they normally would, or whether they've got some kind of clotting disorder that has been previously undiagnosed. That's just an underlying cause. Most people seem to get along just fine until they hit middle age, and then something happens. They have an extraction, they have a root canal, they get hit in the face, or just spontaneously things happen. But we have to assume that at that point something occurred to put them over the threshold. They had an underlying problem, and now they've got a disease, and usually it's a pain-producing disease. This is a good definition. Osteonecrosis is not a single disease. It's a localized pathologic event that results when there has been impairment of the circulation. That's one of the confusing aspects of this disease. Lots of things can produce it. What we're looking at is the end point of a lot of different bad physiology. Normally, as I've mentioned, this is until we get more prevalent studies on NICO, we have to assume that the hip is the most common location. And about 1 out of every 7,000 or 6,000 people in the U.S. have this disease in the hip. This is what we see. In the hip, there's a lot of pressure from above, and so they get collapse. But there's kind of a chalky look to the bone, and if you get further out where we don't have complete necrosis, but we have the kind of thing we see more in NICO, there's kind of a brownish, bloody look to the tissues. And microscopically, that's a combination of red blood cells out in the tissues, not just in vessels, as well as a bunch of fibers. And here's an area of just a bunch of greasy fat that has more recently infarcted. One of the most difficult things for me to overcome is this whole idea that there's got to be a single event that causes this. I now think of this as a triggering event. But for something like a tooth extraction, to cause a pain condition that is eventually proven to be NICO, there almost has to always be an underlying problem, a blood flow problem. Regardless of what caused that problem, there has to be that going on. And in the hip, this is also something that they have found. It might be a single massive infarction. Back in the 60s, this disease was called coronary disease of the hip. That was the term. You read the papers from that time period. And it is essentially an infarction which goes on. But since it is not always a massive infarction, we normally have to assume that there are a lot of little infarctions going on over time. And that's why we can have this kind of a phenomenon. This disease, osteonecrosis, is in the hip, found on both sides. If you follow people for a long time, 10 years or so, 50 to 80% of them will have complete crushing or collapse of one side, and then the other side. Excuse me. I had lunch with Chris Husser, and I guess it's catching up with me. And how many diseases, even back when they were thinking this is an osteomyelitis, how do you explain an infection which goes to the other side of the body and doesn't seem to involve other bones? If you have a phenomenon of poor blood flow, then you can understand. These are the joints that have the most pressure. They have the greatest amount of pressure on them. There's also just a single vessel going in to feed the end of the femur, the femoral head. And so there are reasons to understand this bilateral disease if you think of this as a blood flow problem. And it really becomes quite simple at that stage. However, that took a long time for people to figure out. In the jaws, this has also been something that has caused difficulties. There is a reason, if you think of this as a blood flow problem, for having multiple quadrants involved. This is so far the only autopsy case we have. I showed this as sort of a kickoff picture in a lecture which I gave to the bone path people at AFIP, the Armed Forces Institute of Pathology, because the head of that bone section is one of the experts in osteonecrosis. And he just looked at it and he said, "Boy, that's the most convincing thing you've given me, you could give me to explain that this is osteonecrosis." None of this showed up on an x-ray. This is old fibrous and old hemorrhage in a surgical site in the cuspid area. An endodontist had found that site, and actually the pain considerably diminished even though we didn't get good healing. I don't know if you can see this, but we have a kind of a glistening, greasy tunnel. There's a little strap of tissue here. It's a little cavitation, and where is it? It's right down on the inferior border. You could have found this. This did not show up on an x-ray, but this is a massive, this is so mushy I could stick my finger in and just scoop it out. And look at all along the canal. The bone has been destroyed and replaced by similar tissue to this. So in one jaw, we have 4 or 5 different sites of involvement. Probably they were triggered over different periods of time. And some of those are so far down in the bone that we could have been scraping forever and never really gotten all of these lesions out. I did a study of a bunch of these patients, and you can see that even though multiple sites and even multiple quadrants are very, very common, we still get about 2/3 of these patients who only need one surgery or maybe a repeat surgery but at the same site. So most patients still only have to deal with a single problem. This is a little summary of who gets involved. Usually it's female. 3 out of every 4 patients are women. They're usually middle-aged women, 35, 45, 55 years of age. We've had this in patients as young as 12, and now we're as old as 94. Most patients have had no teeth in the area for many, many years, maybe decades. When teeth are in the area, 2/3 of them have had endo treatment, but I don't know if that's because the endo, I mean, that would make a logical treatment in somebody who has pain that can't otherwise be found out or explained. And so I have no idea whether the endo is triggering this or whether it was a cause of the pain. This information comes from biopsy reports. 92, actually it's down to 90% now of these people have some kind of facial pain. And I'll talk about thrombophilic and hypofibrinolysis problems in a little bit. Another key part about this disease, I've mentioned it I think a couple of times, not everybody has pain. Until 3 years ago, I'd never met a NICO patient who was not in pain, of one form of pain or another. Now that I have got a wider range of NICO cases coming in from different surgeons, it's several hundred surgeons now, mostly general dentists, by the way, from all over the country, 38 states so far, and lots of different countries as well. But now that I've got a broader base, I find that about 10% of my biopsy reports don't indicate any pain at all. And I suspect that if we really went out into the world and cut a bunch of jaws up, we would find that the typical NICO patient does not have pain. I was calling these cases silent NICO cases, but I don't really think we have to do that. NICO kind of encompasses that whole thing. But look, this is taken out of the textbooks that seem to understand this the most are the rheumatology textbooks. If you want to understand osteonecrosis, there are 4 or 5 of the current rheumatology textbooks that have good explanations of what's going on. And that's much more, they're much more attuned to this than any other group except perhaps the dentists. Initially, the patient is asymptomatic and may remain asymptomatic until after something shows up on an X-ray, a CAT scan, a CT scan, MRI. Or in many instances, there's a significant amount of pain before any X-ray evidence of the disease. And that certainly is true in the jaws, but the statement is made for the hip. Why do we have so much pain? They don't call these neuralgias in the hip, they just call it pain. It's referred, it could be referred down to the foot, it can be referred to the knee, mostly it's referred to the groin. Can be referred to the buttocks. It can be referred to the rectum itself. And there are lots of weird referral patterns when it's in the hip, but they don't put the term neuralgia on. But in the jaws, we've got, in the facial area, we've got this term that we give people when we can't understand why they have pain. And if you know also that 90% of all neuralgias in the human body are diagnosed in the face, you have to wonder why that is. And here it is. We are the only bones with large sensory nerves. No other bones have nerves. I mean, they have nerves. They have proprioceptive and other kinds of nerves for vasoconstriction and whatever. But you can literally, once you get into a bone marrow and any other bone in the body, you can scrape all you want without anesthesia. Once you're down through the cortex, there is no pain that the patient will feel. And we're dealing with the only bones in the human body with nerves right down through the marrow spaces. And we're dealing, you put that on top of the bones most likely to be traumatized by extraction or whatever, the bones most likely to have infection, and that infection goes right into the middle of the marrow space. I mean, it's like a time bomb just waiting to go off. I'm surprised that, I would be really surprised if it doesn't turn out that the jaws are by far the most common site for this disease. Well, almost everybody I mentioned until recently whom I had talked to or knew about this disease had some kind of facial pain. I'm kind of fortunate because by the time somebody comes to me for NICO diagnosis, a workup at least, they've already been through a dozen docs. I took 50 cases at random out of the files, and the average patient had been to 32 doctors before anybody even thought about maybe something's wrong with the bone. And these are the kinds of things they were diagnosed with and treated for. About 2/3 of them have atypical facial pain. About 1/4 of them have either phantom pain, headache, those are kind of nebulous terms, different kinds of headaches, including migraines. Initially, my sample pool had 50% trigeminal neuralgia, and that was really a problem because here's a silly dentist telling neurosurgeons that we can stop this pain by cleaning out these things in the jaw. But now, as I've got a wider pool of contributors, we're down to about 10%, and I suspect that will become even less in the future. And of course, a bunch of them now don't have any pain at all. Why do we have these different pain syndromes? I haven't the foggiest idea. This dead tissue, not all NICO cases are total death. There are ischemic changes, low oxygen, poor blood flow changes that are obvious in the marrow spaces. But if somebody has that kind of a disease, will they then get something like atypical facial neuralgia or a phantom pain? It has been shown that you don't even have to have microscopic changes for this disease. One of the ways to diagnose osteonecrosis in the hip is to inject saline into the femoral head, into the head of the femur. If you do that, there's only one disease that will not allow that to totally, the saline, the water, to totally be removed as fast as you can inject it. And that one disease is osteonecrosis. So if there's nothing that can be seen on an x-ray and they inject saline into this hip and the patient goes, oh, that really hurts now, that's the diagnosis. Even without a biopsy, that's the diagnosis. So in those patients, there may or may not be something visible to see. It's a physiologic change. It doesn't have to be something that I can see under the microscope. But perhaps somebody with trigeminal neuralgia has a full-blown, one of these huge microinfarctions, or not microinfarction, but a vascular event, an infarction, right around the inferior alveolar nerve. Maybe that's what causes the huge triggering pain. And maybe other people have it some distance away from the nerve. We don't really know the answer to that, and I don't pretend to think that we'll get the answer to that anytime soon. I went down one of the many wrong tracks that I took was thinking because of all these neuralgia-like pains, initially I was thinking these were neuralgias, but for political correctness now I'm just saying they're neuralgia-like. There's so much like neuralgia pain that you can't tell the difference until you go into the bone and find out. But every once in a while I'd find a case where the lymphocytes are around a nerve and man, they look to be chewing that nerve up, and I can see where that would be a painful condition. But this is not the typical case of NICO. I've probably, out of 4,000 plus cases that I've examined, I've probably only seen that a dozen times. And then there are cases like this where it looks like little bone spicules are literally pushing in and crimping on the nerve from necrotic debris, and maybe that's a major problem, but I hardly ever see that. Maybe it's because this is a disease, ischemia. One of the events, one of the results of ischemia to any nerve in the body is a loss of the myelin sheathing. You lose the insulation around the electric wires. This is what a normal nerve looks like. It's in a NICO case, but we stain this specially for myelin. It's that blue-green color. And you can see that in the jaws, the vast majority of nerves have myelin sheathing around them. This is a microscopic example without that stain of a nerve that has kind of a splayed out appearance. If you looked, I should have mentioned that. You see how nicely outlined this is? There's an epineurium. There's a nice demarcation between the nerve and the outside tissue. In NICO, in a lot of cases, there are a lot of nerves that look like this. I didn't know what to call it. Degenerated, splayed out, edematous. But look at this. This is such a weak nerve that even fat cells, as fluid as they are, can cause indentation in these nerves. Is this somebody who had steroid therapy, so all the fat cells puffed up a little bit and put pressure on not only vessels but the nerves? I just don't know the answer to that. But it might explain some of the pain. And here is a very common example of the nerves in NICO. You can see just a little bit of myelin sheathing left behind. If we stain for the nerve fibers, they're still there, but the myelin sheathing is gone. So it would be like taking a bunch of electrical wires and just putting them all very close in contact with each other. Very serious problem, I would imagine, but I have no idea if that's the real cause of the pain. However, one of the problems we deal with myelin is that it's such a good insulator that your immune system doesn't know it's there. Most of the time, you will not have, even though you've had injuries in the past, if you healed properly, your immune system will not respond to myelin. We have a disease that sort of causes the myelin to dissolve or somehow disintegrate or degenerate. And what does that do? Does the immune system now recognize? This goes on for years and years, probably. Does the immune system now recognize that myelin? And is that why people with NICO have all these weird pains all over their body? Because now they have antibodies against their own myelin sheathing all over their body? Well, it makes a certain amount of sense until you understand that a lot of the NICO cases with pain in the knees, for example, the pain goes away almost instantly after the NICO surgery. I still haven't got an explanation for that. But in the long term, what we did is we sent Bob McMahon in Indianapolis, and I worked on this. We read a paper about from the University of Maryland. The MD, PhD neurophysiologist was looking at people with multiple sclerosis and Guillain-Barré's disease, seeing what levels of peripheral anti-myelin antibodies they have. Anything above 0 would be abnormal, and maybe that's why some of these medications like Tegretol, they're supposed to do nothing more than stabilize the myelin in the body. Maybe that's why they help people with MS. And maybe that's why they help people with trigeminal neuralgia. Who knows? Well, we sent blood over there, and she called one day and she said, some of your patients are normal. They have no anti-myelin antibody. But you've got some that have levels higher than anything our MS patients have. And we presented that at a meeting, but I just got way too busy, and Bob McMahon now has been waiting for me to do my share of work on that paper for about 2 years now. But it has been published at least in abstract form. And that wasn't us doing anything except sending blood from NICO patients. So it is possible, at least more than theoretically, that somebody with this sort of toxic dump in their jaws at all times is having a systemic effect. This is only one mechanism. Recently in the journal Stroke, there was another mechanism. People who have strokes and clotting disorders have a much, much higher chance of having an infection or a minor trauma within 2 or 3 weeks before their stroke. The thinking is that in people, this could be a dental infection, could be an NICO lesion, could be a toe infection, but a single focus, remember the old focal infection theory? This paper says it a whole different way. A single focus of infection somewhere in the body in people who have clotting disorders. And I'll talk about some of those clotting deficiencies. They're listed in the NICO handout. Can trigger clotting all over the body. All over the body. In septic shock, this happens big time. I mean, people die from that. We're talking about a much more mild sensation. But their big question is this a major cause of strokes? And they kind of concluded that yes, in fact, it might be. And I'm sure there'll be much more research in that category. Well, there was a fellow named Charles Gluck, Dr. Gluck, the head of the cholesterol center at the University of Cincinnati in 1994, wrote a paper. He had 25 patients with this disease in the hip, and 72% of those patients had clotting disorders. And for those of you who haven't gotten into it, I knew nothing about this until recently, but the whole field of clotting has just exploded. When we talked to him in 94, did I say 94 or 74? 94. When we talked to him in 94, he had a battery of about 6 clotting disorders. He had made up 2 of the tests because we just didn't have any way to diagnose this. And of course, until we get a test for a disease, we don't have that disease, right? Because we can't figure it out. Well, now the battery is up to 12 different tests. And, but using his original group of tests, we went to him, Bob McMahon and I. This is a guy with 400 research papers. Most people never have more than 50 or 100 research papers in their life. He's about my age, and he's got 400 already. He talks like a machine gun. He's a Harvard-trained physician. He started the conversation by saying, I just want you to know that I've never had any respect for research done by dentists. And now he's our biggest ally. He is just going great guns. He was invited to give the talk on osteonecrosis and clotting disorders at the latest. There have only been 4 international symposia on osteonecrosis, and the latest one was only last fall. And he tossed the jaw data in every bit as much as he tossed the hip data in. He thought that it would take years for us to get enough patients coming through his clinic. But he finally said, okay, if your patients are going to pay for the tests, I'll do it. So all we did was identify people, send them down to the University of Cincinnati. In 2 months, he had 50 patients. By now, he's had hundreds of patients go through his clinic. Now we have Indiana University who's developed a battery of tests for the same thing. And both of those labs are coming up with the same conclusion. Anywhere from 72 to 80% of patients with NICO have 1 or more major clotting problems. And once I started thinking about clotting, I looked around, and lo and behold, I would find, fibrin is pink. Fibrin is what becomes a scab on the outside of the body. It's tough stuff. But there's no way it should ever occur inside a blood vessel. But I do see this, and not a lot, because I'm dealing with little chunks of tissue, of course. But I've seen probably scores, maybe hundreds of examples by now with fibrin either within vessels or maybe out here in the marrow that otherwise looks pretty normal. And you see the dilation of the vessel behind. Normally these vessels are so small, like here's a normal, whoop, that's the edge of that one. This is probably a normal. They're called sinusoids in the marrow. That's the normal size. Maybe we've got another one here, maybe another one here. So you can see we're 50, maybe 100 times larger than normal. And probably that's backup pressure. And if you look at the osteonecrosis literature from a pathology perspective, the earliest cases are dilated veins or sinusoids. Here is fibrin. Because it's pink and so much of the background is pink in this tissue, I think I was just missing it as I went along. And to see how dilated that vessel is. Whoop. And what happens if we equate the jaw lesions with the hip lesions, which I think is a legitimate premise, we get a clot. And there's no blood flowing through this vessel. These are fibrin clots. Fibrin cannot make a very large clot inside blood vessels. And so only the smaller vessels are involved. Capillary beds, small veins. But nevertheless, we get a blockage. No more blood flows through, and that vessel dies. And then the endothelium just lets the blood that is trapped inside flow out into the surrounding tissues. So there's research out of Japan that says all they have to do is find some of these blood cells in the bone marrow, and that's their diagnosis of an early osteonecrosis. The definition microscopically is changing as we speak. And I mentioned, sometimes we just see the dilated vessels, and we don't see the clot at all. And sometimes we'll just see the hemorrhage, and we don't find the dilated vessel or the actual vessel. It's out of the plane of the particular slice. Here we've got hemorrhage with a bunch of fibrin right next door. This is as normal as any bone gets in my lab anyway. Here's some histiocytes and a little sinusoid. This one has got some red blood cells, just for comparison with normal. I found out that most oral pathologists, myself included, don't know what normal bone marrow is. What are the limitations of normal bone marrow? And perhaps one of the most surprising things that I discovered was all this fibrosis, kind of a wispy fibrosis. There are lots of different names made up for that. in this disease, depending on who first talked about it. Reticular fatty degeneration is what I like to use, but that's all you need for a definition of osteonecrosis, an early diagnosis or a mild case, if you will. And we get a lot of that in the jaw lesions. Well, why have we been missing this? I missed it myself many, many times. Microscopically, I remember the first case that I had was some fibrous marrow in a space that looked like just a fairly well-defined radiolucency in an edentulous jaw. It was in a site that had a root canal at one time, and so this was back in 1972. I remember it because there are so few diagnoses where I couldn't imagine what name to give it. So I called it a residual periapical scar, which is something that doesn't exist. You won't find it in any textbook, but it kind of says the same thing. This fibrosis of the marrow is what happens under ischemic conditions, whether it's caused by infection or some other process. And so that kind of made sense. But other oral pathologists have called it that we've given descriptive terms microscopically to this, but I think most of the time we just haven't seen it. Clinically, the reason for that is because it's so difficult to see radiographically. It is true. This is a disease, perhaps as much as any I know of, where Albert Einstein's quote does hold true. What you see depends on where you stand. If you are attuned to this disease, you'll find it without too much difficulty. If you don't believe in it or you don't think about it, you're never going to find this disease. I can't tell you how many cases I've had after they've been to all kinds of pain clinics and dental schools, and because somebody doesn't accept the concept of this disease, they interpret changes on the x-rays their own way. And their interpretation is these are just variations of normal. And perhaps they are variations of normal, but I've tried to find explanations for those variations and have not found it to be the case. Maybe this is a good example of that. This is a case of NICO. There's something very unique in this disease. They're called wormholes. This is probably a vessel that clotted off years ago and just died away, left a little fibrous scar along the edge. This is from the autopsy case. And wormholes are very commonly seen in this disease in any other part of the body. I couldn't understand why we had these perfectly round holes going sometimes a couple of centimeters in the jaw cases that I looked at. But a wormhole is a very unique thing once you know what it's all about. But if you look at the bone here, a lot of osteocytes are missing. And the classic diagnosis from a medical pathology perspective for osteonecrosis is missing osteocytes. They look at the bone. I'm looking at the fibrosis and all kinds of other changes in the marrow. Well, keep that image in mind. Look at it a little different way, and you know exactly what the cause of this disease is. It's all in your perspective. And perspective is something that the clotting disorders, this has been now published in 2 papers, one medical journal, lab journal, and in IIO in dentistry. We sent off another paper recently, and we've got 2 more in the works. But essentially, this gives a list. I don't expect you to keep them all in mind. They are listed, as I mentioned, along with these percentages or some similar percentages in your handout. And at the time I made this slide up, of our total of patients, 78% of our NICO patients had clotting disorders. These are people who are middle age, and they're mostly women. They've had these clotting disorders that are mostly hereditary. Some of them, like lipoprotein A, you can get as an acquired thing. Some of them are found in things like lupus, these so-called collagen diseases. But many of them, essentially everything up here above my hand, is a hereditary disease. If they had this since they were a child, why do they wait until they're 40 years old to get the disease? And I think it's just the body's getting older, and the whole flow of blood throughout the body is getting that much less. With women, one of the key factors that triggers this is estrogen. And how many women are given Premarin as soon as they think they're hitting menopause? Premarin is a cause of osteonecrosis in the hip, and I presume a cause of osteonecrosis in the jaws. So this is a major breakthrough. We now know what the major problem is underlying many of these people. Why they have the clotting disorders, we don't always know. And the infection is still certainly a major facet of this disease that we just don't understand. So while this is a major step, I don't want you to think that this is the end of it all. When Indiana University got involved, we had a fellow there, another world-famous expert with over, I think, 600 papers to his name. And he said, well, I've got some DNA analyses for some of these clotting disorders, so let's look at it. So one of these can be done by just sending blood to these labs. But the two DNA tests are for factor V Leiden, and that's in your list. And then the MTHFR gene, or abnormal gene. And these are, it's kind of neat having these tests available, but you see that if we look at people who have this gene in their blood, a lot of people have problems that we weren't even aware of, and they're getting along just fine. This kind of data is what makes me think that maybe we're dealing with a problem that's much more generalized than we ever thought about. Think of diseases like fibromyalgia. You get a pain here one week, a pain there the next week. Is that a little microinfarction going on in their muscle? Who knows? Dr. Gluck thinks that this might be one explanation for some of the sluggishness of chronic fatigue syndrome. They've just got a kind of a sluggish flow of blood throughout their entire body because of these clotting disorders. So there are a lot of things that we could think of, but keep in mind, until 3 years ago, nobody knew anything about this. So we're just getting, and the first papers were just published last year. So from a dental perspective, what we have to do is keep in mind that we have triggering events. We have to assume there's some kind of an underlying problem with the bone. And that's where you can imagine the bone has been irradiated. And just whether it has or not doesn't make any difference. That makes you think that this bone is bad. There's something wrong here. But these are the kinds of things that trigger. Somebody goes on an alcoholic binge, or they don't eat. Nobody knows whether this is a nutritional problem or the alcohol causing liver damage or the alcohol causing bone damage. Caisson workers, over half of them are going to get osteonecrosis somewhere in their body if they work for 20 years as a Caisson worker. Corticosteroid is one of the medications that we can produce this disease with. Estrogen, and what do? Somebody has a wisdom tooth removed, and oral surgeons frequently will give a Medrol dose pack to keep the swelling and the pain down. Estrogen, very, very commonly used drug. Anybody who's got a history of cancer has had this disease, at least in a mild form, because chemotherapy routinely does this to bone marrow. And it's just the luck of the draw, whether it's the jaw and the patient ends up in your office, or whether it's the toe and the patient ends up in a podiatrist's office. Pregnancy is a key kick for the younger people, a key triggering event. I mentioned cavitations. It was a very, very unique feature of this disease. The word cavitation was first used in the bone literature for this disease back in 1930. Fiemeister at the University of Chicago, they named a building after him, which is still up today. He is one of the premier bone researchers of this century, and he made up that name, cavitation. G.V. Black used the word cavity in describing what the bone looked like inside patients with what he called chronic osteitis. These are the only disease I've been able to find in the literature that produce hollow spaces in the bone. Ischemic osteonecrosis, we've been talking about. I've got one of these in my own knee. Arthritic patients, probably a quarter of all people with arthritis have osteonecrosis in the underlying bone, but nobody has really bothered to look very, very often at the underlying bone. They're worried about the cartilage surface. But subchondral cysts are very well accepted as hollow spaces that occur in arthritis. Osteoporosis, somebody with osteoporosis has quite a few, but they're usually very small. every once in a while they get very large. It's kind of interesting, the premier authority for this disease, in the hip anyway, is Peter Bouquot, who's the head of pathology in the New York Special Surgery Hospital. They probably do more bone surgery than any other hospital in the country. Well, he's using the term, I like to use the term tissue type 1. I follow the French system, tissue types 1, 2, 3, and 4 for osteonecrosis. He doesn't use the tissue types. For the mild cases, the kinds of things that we see in the jaw, he uses the term that the radiologists have used, transient ischemic osteoporosis, because on the x-ray that's all it looks like. Somebody walks in with some pain in the hip, they take an x-ray, and the femoral head has osteoporosis. Nothing else in the body has osteoporosis. It's a regional phenomenon, and it migrates. One of the terms is migrating osteoporosis. So we are at this time going through a terminology dilemma, but pathologists are used to that anyway. So we do agree that it's the same disease process. We're just arguing about terms. Traumatic bone cyst, I think, is just another form of NICO. In young people, for some reason, there's less pain. And there are other differences, but really minimal differences. Certainly microscopically, there's no difference between the cavitation of a NICO lesion and a traumatic bone cyst. And some traumatic bone cysts, I should say. And then there's a funny disease with a lot of sclerosis that ends up with these traumatic bone cysts or cavitations. It's not commonly found. Florid cemento-osseous dysplasia is the term that we use. But you know, if you took a jaw, I didn't put a picture in, but if you took a jaw involved with that and turned it on its side, it would look just like all the white, the sclerotic material that has been created would look like smoke coming up a chimney. And in osteonecrosis of the long bones, that's one of the signs the radiologists use. Smoke in chimney, that's their radiologic sign. Smoke in chimney for a lot of osteonecrosis when it not is on the end of the bone, but more in the shaft of the bone. So maybe that's the explanation. Maybe these are all the same disease, and we just haven't made up our minds yet to accept that. Well, the cavitations usually are up in the head of the femur, but here we have a similar phenomenon going on, the hollow spaces. The radiologists even have a special classification. This has been superseded by a different classification system, but the one until a few years ago had type 3 lesions, which were cystic on the x-ray. I mean, they assumed that it was a cystic lesion, and of course surgically it was found to be the case. This is the flip side of that autopsy case, and you can see there's a lot of cavitation or hollow appearance to this. And who knows if all these smaller spaces, they're definitely hollow. Is that because this is ischemic bone and this fellow has had a problem for a long time? He certainly had pain for a long time. He was from Indiana and he had pain for 7 years. He had trigeminal neuralgia of the maxilla and atypical facial neuralgia of the mandible. And it took some endodontists, believe it or not, to get him out of pain. But it started to come back, and he had other health problems as well. He died of sleep apnea. If that's the case, was sleep apnea giving him ischemia every time he went to sleep? Is that what produced? Maybe all of his bone looks like this, but we only got the jaws. So what you see depends on where you stand is certainly true for this disease. Also, hot glass looks exactly like cold glass. You can look at an x-ray and see nothing, or I can look at it and see something. And I've had perfectly good oral surgeons, friends of mine, people who trust that I know what I'm doing, and I say, look at here. There's a lesion right here, and they won't see it until I actually take a pen or pencil and outline the area. It's a very subtle change in many, many cases. I happen to feel fairly comfortable with x-rays because Alex Roberts, the oral surgeon in my state, that's how he diagnosed cases. When I first looked at his cases, I could only pick out about 10% of the cases. Now I can pick out 80+%. And it's just been experience that has led me to that. So let's look at some of these things. One of the problems we have with this disease is that it's got a fuzzy margin. Many times they look fuzzy white or look kind of brownish, as if somebody's taken a blowtorch to the inside of the bone. And any kind of radiographic image that has a fuzzy margin has no image at all. So because of the nature of the lesion, it's very difficult to see. And if it was very sharply demarcated, we wouldn't have nearly the trouble we have trying to isolate and identify these areas. This is from the ADA Journal back in 1964, I think. Somebody took a dried skull, took an x-ray. You can see up at the top, we've got a shoulder in the way. Maybe someone can move the shoulder for right now. But if you look at this x-ray and compare it with that x-ray, to me it looks exactly the same. I can't see the difference. But this is what the bone looked like when that x-ray was taken, and this is what the bone looked like when this x-ray was taken. We have been telling each other for years, certainly in dental schools, that you need at least 30, 50, 60% of cancellous bone to be disappeared or gone before it shows up on an x-ray. In fact, it's very obvious. I mean, these papers have been around in the standard journals for a long, long time, and every radiologist knows about this. And yet, if they see nothing on an x-ray, they say there's no evidence of osteonecrosis or osteomyelitis. In the long bones, when a radiologist sees nothing, they say, well, could still be osteomyelitis. It doesn't rule out. A negative x-ray does not rule this disease out. This is the staging, the radiographic staging system now in place for osteomyelitis of the hip. Look at stage 0. All techniques, MRIs, radionuclide scans, x-rays, CT scans, everything is negative. And yet they've got the disease. The only way you can prove it is, well, they didn't talk about injecting saline, but the only way you can prove it is actually go in and get some tissue. This is the only disease that I can find in any of a dozen radiology textbooks that I've looked at that has a stage 0. So I think if the devil was going to invent a disease that was hard to diagnose and even harder to treat, this really would be the disease. I can see where people have doubts about the existence of NICO. But keep in mind, now in some studies, as many as a third of all osteonecrosis cases in the hip are stage 0. There's nothing that we have in our technology today that will find it for us. But biopsy. And people are constantly being criticized for scraping out biopsies. I think if you're going to curate a NICO lesion, just say we're going in to explore and do biopsy of the tissue. And of course, when you're in there, you can clean everything out just fine. But that's a legitimate protocol. Well, does anybody see anything here? We've got a little bit of light, so it might be difficult. But the only thing I can see here is kind of a triangular, maybe a residual effect left over from the extraction. This is the kind of a thing that I see, and those of you who treat NICO have seen it all the time. I'm writing a journal or a paper for the Journal of Prosthetic Dentistry called Subpontic Osteonecrosis to emphasize the fact this is the kind of disease where there was pain in this tooth. The patient went through a root canal. The tooth eventually was pulled, and then the pain went down for about 6 months. And the patient came back and said, everything's fine, let's put that bridge on. And as soon as you cut the bridge down, the pain starts all over again. And then they want that tooth out and this tooth out, and you've, of course, caused all of this problem. But the problem is right here, and the cleaning out should be done right there under the pontic. This is one that I think even I could see in my early days. There's just a black hole, not too well demarcated, but it's visible. My secretary could even see that one. Well, these are the kinds of appearances that we see fairly typically. There's kind of an osteoporosis look, and if you know the terminology that I just explained, that certainly seems valid. If we do see a radiolucency, it's hardly ever well demarcated. And there's a lot of lamina dura left behind from teeth that were extracted years and years, maybe decades ago. Initially, the cases I saw didn't have the apex, so it was hard to say that they were outlines of sockets. And so I just used the word laminar rain, which seems to have kind of stuck. But those are just residual lamina dura. And the alveolar canal. I just am working with a PhD anatomist who found a paper that was just published last month in one of his anatomy journals about the alveolar nerve and the variations of the alveolar nerve. And part of it was X-ray changes. And they did a literature review and a nice paper on about 30 or 40 cases, if I remember. And they said we can always see the outline of the alveolar canal, always. And in the literature, almost always, according to the papers that are out there, you can see the outline of the alveolar canal. So if you can't see the outline, maybe there's some anatomic variation involved here, because some people have a little groove on the lingual aspect of their mandible, and there really is no complete canal for the neurovascular bundle. But nevertheless, if you look at the literature, it says you shouldn't have loss of that. And so a destroyed alveolar canal is kind of a major feature. This sort of has it all. I saw this at surgery. Here we can see this was all mushy. This was a hollow space. That was fibrous tissue in the old third molar site. But look at this canal. It just kind of disappears right here. And if you look carefully, and if the light was turned off, we would see that instead of blackness here, like true osteoporosis, there's really a haze, a very faint white haze, like a ground glass bone in fibrous dysplasia, but much more faint. And lo and behold, the radiologists in the hip osteonecrosis cases have come up with a name for that. They call it ghost marrow. And this haze is made up of little chunks and bits of old dead bone, probably sitting in this coagulum of necrotic soft debris. So this is, to me, a classic example of osteonecrosis in the jaw, and yet I've shown it to people who have often said, this is perfectly normal. And it takes cases like this to make them wonder. There is no literature data that says that a socket should not remodel within 6 months to 12 months. And yet that's almost accepted as standard. All of you in your dental practices have seen lots of people with sockets left behind, usually in wisdom tooth areas. Well, if you believe the literature, all of those people have some problem that has prevented it. It probably is blood flow. It could be low-grade infection. It could be a hypothyroidism. Maybe they've got a metabolic problem. But there has to be an explanation for it. You might not have to do anything about it, but if that patient also has pain, then this is just a little red flag that tells you that whatever problem they have, they probably had it back when they were 18 and 25 years of age and had these teeth out, even though that was 20 years ago. The problem was way back then, and it has continued to this day. There is no explanation. If you look carefully, this even has the Jacob's ladder, you know, the trabecular pattern holding the roots in place. There have been no roots in this jaw for decades. And if you look carefully, you'll see this isn't white, this isn't black down here. There's a ghost marrow look to the marrow down below. Now, taken one by one, these might not give you a proper diagnosis, but when you combine all of these changes, and especially in somebody with facial pain, I think you should be real suspicious. And this was one case where you can see the laminar rain or the residual sockets, but there was a little nipping away of the cortical plate on the top of the ridge, and so I just took a needle and kind of bounced it off of the mucosa, and you can see what happened, just fell right in. So all of this was just one hollow space, and I would have told the surgeon to go over here. So now I'm telling the surgeon to go on the bone around that root structure and see what's there. Oh, by the way, do you see the inferior alveolar canal down here? And look how far. It hurts. I probably bounced the needle right off the nerve. And sometimes there is an attempt at remodeling, so you don't get this actual socket outline. It takes on a little bit of a soap bubble appearance, where chunks of the lamina dura are kind of pushed sideways by this granulation tissue or fibrous tissue, and it just doesn't heal. And this is what Roberts has taught me. I didn't make much of it until I started looking at a bunch of cases. He called this the eagle's nest. It looks like sticks have been sort of placed around a central core where the eagle, the baby eagles, might be. And if you look carefully, this wasn't a subpontic case, but this bicuspid had been removed many, many years ago. But you see, almost it's thin, but it's definitely the outline of the tooth. You press that area, it's tender. And this happened to be the case from an old x-ray from this autopsy case. This is the upper jaw. There was no cortex here. There was no cortex into the bone. This was just fibrous scar tissue in the bicuspid area. Why this particular extraction didn't heal and others did, we don't know. But nevertheless, those sockets, if they're not hollow, they're usually filled with fibrous tissue. And fibrous tissue needs the least amount of oxygen. That's why we end up with fibrosis in ischemic states. And then this is a picture from your handout. The tuberosity area is hollow many, many times in this disease. And then we get cases that look a little strange. I can't even see it here, but what I've taken to doing since I've started with this disease is I have a little cubby hole in my office where the lights can be turned off, and I have a viewer in a drawer, and I have a magnifying glass, and so I look at all NICO cases the way we're supposed to do it, the way we're all taught to do it in dental school, instead of just holding it up to the light like this. And in that setting, can you see an arc right here? Many people can't see that until I point it out. I couldn't see it until I got it under my magnifying lens. But that whole thing was just mush, entire mandible, or maxilla. If x-rays don't show anything, there's another good test that just by the luck of the draw we happen to hit on. There are lots of radioisotope bone scans. If you think this is an infection, you'll try gallium and indium. They're always negative in this disease, always negative. And so your patient gets them, and they assume, whoop, there's no infection, no problem. But technetium-99 is one of the oldest of the radioisotope scans, and it finds new bone. So if your patient is lucky enough to have a little bit of new bone healing going on, there will be a hot spot in the jaw. And as a matter of fact, it's in at least 2/3. There's a group out of Indiana that claims that 80% of theirs, they've trained their radiologists to identify 80% of their patients will have a Tech-99 hotspot. Hotspots in a radiology report might not even be reported if it's in the jaw, because in their literature it says 1/3 of the jaws have hotspots. That's from gum disease, we assume, but we don't know for sure. So if you're sending somebody with periodontal disease, this test is not going to be nearly as accurate. This was a case of somebody with hot spots top and bottom, 4 hot spots, completely negative to CT scan, completely negative to MRI, negative to all x-rays. Teeth had been pulled over the years because of pain in both jaws. And the only test that was positive was this test. And by the way, the sphenoid bone was also involved. An ENT surgeon went up there in order to eliminate headache. We have had this disease totally destroy the infraorbital bone. This disease has been in the back of the maxilla. It's destroyed the nasal, the septal bone, not the septal bone, but the wall of the nasal sinus. This is not just an alveolar bone disease, but it usually is an alveolar bone disease. And Tech-99 scans with computer imaging that's becoming much, much better. Here you can see a huge involvement in this patient. With the computer imaging, it's much, much easier to kind of pinpoint exactly where the problem is. The latest test, I'm out of time, so just give me maybe 3 or 4 more minutes. The latest test, and one that I'm really excited about, it came about because of implant surgery in dentistry. Columbia Scientific has given me a program to analyze CT scans, CAT scans, the new ones called spiral CTs, give data that, if done correctly, can give me 1 millimeter slices throughout the jaw. Top to bottom, lateral, they can give me any kind of slice that I want. And with this disease, I am able to tell a surgeon exactly. I've only done about a dozen cases so far, but the surgeon has gone into every place I've set it, and there's always been a hollow space or mush in those areas. So I'm starting to feel a little confident, but I still have a long way to go. This is a case where we had just behind this is the anterior jaw, this would be close to the midline, and this would be an incisor. And there's a hollow space right behind the cortex. But if we would have gone in there and removed that, we still wouldn't have found this site. And this had perforations going into the sinus, which is not unusual in NICO cases. The floor of the sinus can look like a sieve. So this is a new technique. If you have access to any kind of DentaScan as one brand name, I would suggest using it. It doesn't take much X-ray, extra X-ray than a regular CT scan. And here is one that has, remember that ghost marrow? Here we have an area of ghost marrow, totally negative on every other test. Could you switch trays for just 2 or 3 minutes here?
What's that called again? The DentaScan?
DentaScan is one, I call them skinny CT scans, but you just ask for 1 millimeter slices, and if they have a spiral scan, they can give you that data. Most of the time, the dental schools, the bigger dental schools, all have DentaScan programs now that will interpret the data and spit out these images. This is a 3D form of DentaScan, and you can see the whole base of this maxillary sinus was just looked like moths had been eating away at it. And that was perfectly normal when an ENT doc went in and looked at the sinus. There was no redness or no puffiness over that area. Is this going the other way now? The latest, and who knows what will happen to this, but a NICO patient, Bob Jones, happened to be an engineer in the sonic business, and he claims to have 5 prototypes now that he's developing. He's looking for FDA approval of ultrasound devices for finding NICO lesions. And he happened to have a neighbor who was a pig farmer, a rancher, whatever, and just by chance, he used those pig jaws from the butchered pigs as his model because they had to do for FDA approval. They have to work out to make sure essentially there's no damage being done and it's a safe technique. Well, out of the 25 pigs that he sacrificed, 3 of them had these images. And if you read the description, he had the New Mexico School Technological Institute, I think it was. It was a project of the students there. And in the thesis that they put together, they say that these are hollow spaces that you could pour water into. And it was, you can see the irregular outline. This is the outside of the mandible, and there's probably a little perforation here. But this is just different depths of soft and hollow tissue. Well, by chance, he used the only known model for osteonecrosis. If you want to study osteonecrosis in the hip, you use pigs because so many of them have osteonecrosis in the hip. And just by chance, he chose the one animal model that is available. And he found 3 out of 25. I haven't got tissue samples to prove this, but he is going to continue this and be sending the tissue samples. So I don't want to get into other forms of testing. I don't want to get into the treatment, but so far, Chris will be talking about that in a moment, but we do have some pretty effective treatment in the old GV Black technique of curettage. You just clean it down to normal bone. Most of my tissue samples don't have much normal bone in them, so I'm getting all bad bone. People who do NICO surgeries are accused sometimes of making big holes in people's jaws, but as far as I can see, the stuff that is getting out of the jaw is the abnormal, and the normal bone is being left behind. With that technique, with simple curettage, 72, 73% of patients are eventually able to be out of pain. They may have to have 2, 3, 4 surgeries, maybe more. But if you stick with them and they stick with you, chances are very good that things will be very good. We are now putting patients on anticoagulants depending on exactly what problem we've identified. Dr. Gluck puts them on, or Dr. Triplett at Indiana University puts them on an appropriate anticoagulant. Some of these have serious side effects, so it's being very carefully done. we just submitted the first paper of 30 patients, and around 50% of these are complete failures from surgery. They never got better. These are the worst of the worst patients. And nobody's been able to help them. And 45–50% of these are dramatically improved in their pain, according to their own pain diaries, after 4 months on anticoagulant without any additional surgery or anything else being done. So this is maybe another breakthrough, but we're still a little ways away from saying that this is the way to treat everybody. Okay, I guess, Chris, do we have any question time? I can handle a few questions before Chris comes in.
What's the relative or the rough expense of the Technetium 99 test?
A Tech 99, it depends on what part of the country, but in my state, you can get one of those for $300, maybe $200. In New York City, it might cost you $1,500.
What's involved?
Tech 99, they inject the radioisotope into your arm in the morning. Patient has to come in the morning. Then they sit around for 4, 5, 6 hours. And at hour 4, hour 5, and hour 6, they sit them down on a scan that will pick up the radioactive output. So it's a very simple technique, and that's why the pictures are so crude.
How do you order it? Is that of the head or maxillum and mandible?
No, that's the whole body. I order a left and right and center head, but then I usually ask for a whole body since the stuff's all over the body. Not all of the smaller hospitals will have the facility to have a whole patient laying out on a scanning a pickup machine table, but they can all do one part of the body, like the head.
Do you do that to check the hip?
As I said, I always recommend a full body scan if at all possible. I always ask people now, about 25% of my patients with NICO, since I started asking, have hip problems. And many of them have hip problems in their family. I always ask now about premature strokes. There's somebody in their 40s who has a stroke or heart attack in their 40s, that kind of thing. Those are just questions that send up some red flags. Parasite has been suggested from time to time, and we have special stains for sort of generic parasite stains, and I've used those stains and not found anything. But that's such a crude way. That's not the way to do it. I would have to say, to date, parasites have not been looked at as a potential problem here.
One of the things you're talking about sound like increased sympathetic flow from
Yes.
RSD from the medication.
Some of these cases in long bones are called reflex sympathetic dystrophy. That's a term that used to be used for just the bone phenomenon.
Looks to me like those cases are really very complex and generalized cases. So what we are doing here in terms of the dental we are giving symptomatic relief, like giving aspirin for pain. And where we should be looking into is increasing the circulation, increasing the oxygen intake, and possibly
That's what's creating the noise.
Right.
I know. It's bad for the lab.
and that's why it's involved that. I mean, we can be treating now, but we think that the real policy is
That's, although we get away with it most of the time.
I know, but we listen to policy here, so
Yeah.
maybe hyperbaric centers should be involved as one of it, supplemental treatment positionally and looking into the history thing of the patient, possibly the genetics, like you mentioned, and occasionally, what else, estrogen and other different factors as well.
The implications of where we go from here are huge once we know about all these clotting disorders and that this is a blood flow problem.
It's like emergency.
Yes.
Open the door and you
Exactly.
see the entrance.
Got a cramp in my hand. Yes, exactly. That's a very good comment, and Chris will probably address the hyperbaric chamber. Until we got into the blood clotting problems, my ideal therapy would be to put somebody on antibiotics, preferably IV antibiotics, put them in hyperbaric chamber therapy, and then do surgery in the middle of all that and extend it for another month or so after that.
Among the triggers you
So far, there's been no real study of which particular race has a problem with these clotting disorders. Keep in mind, 5-7 years ago, none of this was known. So we've just come up with the standards within the past few years. Your point is something that maybe I should at least mention. If you go back long enough, it was very common. If you go back 100 years, it was very common for people to pull a tooth and see a big chunk of the jaw come out. They called that bone caries, and it was due in their thinking to either mercury poisoning or phosphorus. People were making safety matches in cottage industries at that time. And lead poisoning will do the same thing. I mean, mercury, all the heavy metals are in fact producers of ischemia in bone. We've looked at it as toxic levels. I don't think anybody's looked at it as sort of sub-threshold levels.
I have one comment and one question. There's a new software package for radiologists that you can sit at home with your PC and have the CT results from the jaw sent over the internet at home, and you can use the scanner, the mouse, to measure the bone density in all the areas of the jawbone. And it's been really wonderful how to predict the bone cavitations that way. You can sit at home.
CT or Doppler?
No, it's CT. You get the slices of the CT sent at home or wherever you do it, on the internet, and you can use the mouse, put the cursor on the points that you want to measure, and you get these significant drops in bone density where the NICO lesions are. And it's been really wonderful. We use Chris and I use muscle testing, as our indicator.
That's
And
another way of finding it.
as related to the one opportunity I had, we had like almost 100% congruity with that. So we have like actually now a technical tool where we can sit at home and very comfortably determine which areas should be operating and which ones not with that tool. That was just a comment, and I can give you the contact on that.
I definitely would like that contact.
Yeah, yeah. And the question I had.
Oh.
Most of us here are aware
Can I
that
play the guitar, right? No. You're still better than I am.
no, you can still be my friend. Most of us are aware that NICO lesions and related disorders in the jawbone can cause pain problems other than local pain problems in the face. My question to you is, have there been any papers actually on long distance effects or on other illnesses other than pain?
I'm trying to get a bunch of offices together, sort of a multi-center study. We're going to meet a couple of times this summer. I'll be working with Chris on that for part of it. And we're really going to, it'll be a follow-up study more than anything, but we're going to have very detailed medical histories up front. And then after a treatment is made, my office will be sending out the same medical history. And the question is, has anything changed outside of the mouth?
Like an outcome study more.
Yeah, but we don't want to make that, we don't want to tell the patients that that's really what we're interested in, because we don't want them to focus on it. Yes?
I just want to have a comment on
It's all allergies.
on the hidden attack on body on the meal-invasive feed. And you know that it's not just antibodies, it's actually cellular response out of aggression to meal-invasive. And which is very interesting is that why the meal-invasive is a trigger is because it's a lot of SH groups there. It's very fat. So if you induce radioactively labeled mercury, low doses into the rat, and then you're scanning where the mercury is in the brain, so it's in myelin sheath. It's University Inval, Dr. Chang has done that. Meaning that if you have low dose exposure to toxin, and I am sure you have, it's sitting in myelin sheath and it will trigger the rotor reaction to this, and that's very how you find these hints on serum level.
There are dozens of PhD theses that could come out of this single disease. I mean, it's amazing the scope that's possible once you accept the concept. Yeah. George?
Gary, do you find that our protocol for extraction of teeth has been preventive of cavitation?
George's question is the protocol of reaming out, getting rid of the lamina dura essentially after extraction, been helpful in preventing cavitational development or osteonecrosis, and I think it's not a bad idea to do that, but I don't think we've had any studies that compare them. That's just another one of the research projects we have in the future. Yes, Boyd? No, there's that's why Arlay and Ficon in France really helped me out, because they were the only ones, or they were the first ones to say, this isn't just a bunch of dead tissue, there's a whole spectrum of diseases. When I get the dead tissue, then it's pretty easy to show another oral pathologist and say, this is osteonecrosis. And once they accept that, then I can tell them, well, these are the variations. But I almost always start, turning oral pathologists around has been a one-on-one thing. I'm going up to the University of Pacific in San Francisco Monday to do the same thing. I'll sit around, I'm sure, just like every other time, they will be able to diagnose NICO when I'm done with them. But until then, the concepts are just different.
I would just like to ask you a question or tell you something that you can have some concept. Number one, blood clotting can be caused by chemical reactivity.
Absolutely.
Anything that will kill a cell, cause platelet lysis and start clotting cascade. When we test these cavitations that Chris has sent me, they're all toxic. They would kill cells that came in contact with them very quick.
Chris has some of the worst cases from a microscopic perspective, too.
But the thing is that it seems like there are categories of different toxins in different samples that they sent me. Some are very potent at wiping out say, beta-tubulin, and others are potent at wiping out creatinine. The enzymes in general that seem to be the most sensitive are those that have the sulfibrils in their active site.
Yeah.
So,
And you all have to stick around to hear the rest of this tomorrow. Yes.
Have you repeated the scans that you were talking about before and after the surgery?
Yeah, that's been done quite a bit, but I've only seen a few of those. And the radiology reports say there is a drop, but not always in the scan. A drop in heat. Technically, there should be a cold spot in the middle of these things, because especially if it's a hollow one, there's nothing for the radioactive isotope to attach to. But that doesn't seem to be the case in flat bones. You see it in round bones. Yes.
I had the opportunity to give a little talk at a mitral valve prolapse support group in San Antonio, and I was real excited because I thought, well, maybe I could see something, take a survey to see if these people had an incidence of dry sockets and things like that, because from the acupuncture chart so many of us are familiar with, that goes to the heart. Well, I didn't get much response from that, but when I was taking my history from these people, there were 40 people at this little talk that I gave. 36 of those people had root canals. Now, what's the incidence in the general population that 90% of the people would have endo? And I think it'd be real interesting for everybody here, if you have a chance to call your local mitral valve prolapse support group, which are all over the country, if you ever get a chance to talk to them, do a little survey, see what you come up with.
Would be interesting. A year ago, I might have had that figure on how many people, what percentage have root canals. It's pretty high, but I don't recall what it is offhand.
I can jump in for a second. I always thought it was third molar related because I had a young fellow came to me whose life literally went down the tubes with chronic fatigue after third molar extraction, and they developed an audible mitral valve prolapse of grade 2 over 6 quick, or even 3, and I did one side cavitation-wise, and his mitral valve prolapse went away, and we can document it with before and after 2D and MO cardiograms. It was gone. So I think if you look at third molars, but I mean the same infection is in a third molar as in a root canal. Nobody's going to talk about that tomorrow.
I should have pointed that out. Almost half of all of the NICO cases I have coming to my biopsy service are wisdom tooth sites. And I think that's fairly significant.
Do all root canals eventually cause NICOs? Is it like having a dead body in the basement?
I honestly don't know the answer to that. George and I argue about that. I don't think of them as a cause, but like a triggering mechanism. And we just need more data, such as what Boyd is going to be talking to us about, to know that.
What we found is with the electrodermal testing is a very good way for locating these, and also checking after surgery if the area is clear. And you can be very conservative in your surgery.
Yeah, I'm trying to think of the commercial name for the electrical testing. Yeah, well, you know what I mean. I've seen that work, and it seems to make a certain amount of sense. I don't have anything against using that technique. I think it's probably valid. But we have no research that shows that. It's another, yeah.
Jerry, one thing I've been looking at is most of our wisdom teeth are taken out now is under a general anesthetic. And do you have a scenario of how that could increase the likelihood for the swelling?
Or the steroids, corticosteroids that they were given. I mean, it's not me that says corticosteroids cause this disease. That's in the bone literature. That's okay. One more question.
I just want to mention about something that may or may not involve the subject. All these radioactive materials that are used for all sorts of tests, like the heart scan, is done like, I believe it's cadmium, but correct me if I'm wrong, and that breaks down into mercury. So I don't know how many people know about this. So
Does my Tech 99 scan have mercury in it?
I don't know, but
Never
you have
thought
to
about
look
that.
into what they break down into, and nobody's going to tell you. So generally, on this heart patient, it might many times make the situation worse because the patient doesn't even know getting poisoned.
Interesting.
Did
Okay.
she say Valium? Excuse me, what did she say broke down?
Okay, well, let's give Chris a chance to say, I think there's a break. Okay, thank you.
Hold it, don't go away. One announcement. Two announcements. This package came for Val Bentley. Is there a Val Bentley in here? Teresa Kaiser from DAMS has a little announcement to make.
First of all, I want to let you know that if you don't know DAMS, we're a patient support and education group, and you're welcome to refer people to call us for information that you may be afraid of giving out to someone you don't know. We'll tell them all about dental amalgam, root canals, and cavitations for you. The other thing is, we have a silent auction going on at our table, and we have some items that most of you would really like to have for your office. And if you don't know about them, please come by and let us tell you about them. We've got a Dent Air Vac System 4. They've upgraded it since September when I had a System 3 that we gave away at the IOMT, so you guys get the better system. It's got a higher grade motor in it. And it's great for sitting next to the patient's chair. Come let us tell you about it. We've got a couple of other nice things like a germ mercury vapor analyzer. And we'd like to show them to you, and you can get them at a fraction of what you'd normally pay for them retail by bidding on them in our auction, and you'll be helping DAMS. The money goes to the work that we do. One other thing, somebody came by the table and picked up handouts, and I'm sure it was a mistake, but we had a certificate sitting there that was for 2 Empress crowns, and it disappeared. And we need to get that back. It's one of our items that we're auctioning off. So if you go through your handouts, if you've been to our table, and see if maybe you got it by mistake, we'd really appreciate it. Thanks.
Let's take a break for, let's meet back here at about 20 after 4. It's about 25 minutes because we have 2 more lectures, mine and Don Burton.